Great, thanks so much for the invitation to talk here. I'm really excited to talk to you about some new work that we are doing. You saw also some of the posters as well outside. First of all, I'd like to highlight the patient representatives that work together with us in our research, and this is the evidence essentially culminating. Oh, that went too fast. I need to go back. I need to press this button because this is an image based with patient representatives, what PEM is for patients, brain fog, muscle pain, and after daily life activities such as walking up the stairs. I'm going to keep it short because I only have 10 minutes. So I'll go really quickly to the core aspects of our work on skeletal muscle dysfunction in patients with long COVID and ME/CFS. And in our work, we really focus on post-exertional malaise, which is the worsening of general symptoms or the development of new symptoms within roughly 48 hours after physical, cognitive, or mental exertion. The diseases of this particular thing is patient and time specific and can last for weeks or even months if it's serious. Importantly, it's shared across different disease phenotypes, long COVID and ME/CFS, but also other post-acute infectious diseases. And when we talk to patients, we also know that the symptom of PEN can come in very different types of flavors. It can be more brain fog related, muscle pain related, other things. So that's something that we don't really know much about, and our work starts to develop this in more detail, essentially. So we do know that exercise above this PEM triggering threshold is not good for rehabilitation in patients with long COVID and ME/CFS. Unfortunately, the current diagnosis is I would say, an unethical 2-day exercise test where they tend to induce PEM 2 times, essentially, and then say, well, you got worse the second time, so probably you just had PEM. But then you leave the patients essentially going home with a double PEM episode. Better is the DSQ-PEM questionnaire. It's not perfect yet because it's very short and doesn't really take into account all these different flavors of PEM, but it's at least better than this unethical 2-day exercise test. In our work on skeletal muscle function, we tend to focus on a 2-day biopsy test. So what we do is we take a muscle biopsy from patients with long COVID and ME/CFS. We'll talk to you through that later. Like a week before an induction of post-exertional malaise with a maximal exercise test, cardiopulmonary exercise test. We also use that to study the exercise capacity. And one day after, we ask the patients back to do a second biopsy. The study that we published last year got a lot of attention. I'm not going to talk through all the details in the paper because it's been on the screen for some earlier presentations too. I do want to highlight the fact that there were 2 letters to the editor published early this year, essentially telling us everything is deconditioning, which of course we strongly disagree with because we also work on this particular field. So that's why we now focused a bit more on that, and that's coming in the next few slides. Importantly, we highlight in this particular paper the contributions to the reduced exercise capacity, which is indeed the lower mitochondrial respiration, more metabolites related to fatigue, and the Warburg effect. I find it a little bit difficult to talk about Warburg effect in skeletal muscle because it's not necessarily to be exactly the same as the Warburg effect. We see more glycolytic fibers, and that really also predispose patients to become fatigued quicker. But importantly, the pathophysiology of post-exertional malaise is different to the one that where the reduced exercise capacity. Because with the induction of post-exertional malaise, we see rapid local and systemic metabolic changes that are associated with more fatigue. We see markers for muscle damage, but also repair. So we see some repair capacity too in patients. We think there's a link with immunology because we see some infiltration of T cells and macrophages upon the induction of post-exertional malaise, but also amyloid-like structures. We don't really know much about these structures, and we're trying to elucidate more what they are. So there are 2 different types of pathophysiological mechanisms of these things. So it's really important to remember that these are not the same, so to say. We recently been asked, Braden, who's here as well, have been asked to review the current literature on the skeletal muscle changes and what are the current hypotheses in the field. And we highlight 5 different sort of aspects: the local hypoxia and endothelial dysfunction, and also Anouk talked about, and we'll come to that later. Deconditioning, which I don't think is the case, but we'll come to that later as well. Electrophysiological changes, such as sodium disbalances in skeletal muscle. Autoimmunity is an interesting thing that we study and we like to learn more about. And central fatigue. So maybe there is also a neurological component to the reduced excitation, essentially, of muscle. Recently, we published this particular preprint paper that Braden is also presenting outside here in the far corner. And the question essentially is, what are the skeletal muscle abnormalities that we see in patients with long COVID and ME/CFS? Are they really distinct from strict bed rest? And we do some strict bed rest studies in collaboration with ASA and NASA and the DLR. So actually work that we do here in Cologne. And we try to separate out essentially the change in the skeletal muscle and upon exercise responses in those 2 groups. So the long story is on Braden's poster, but this is the super short story. We see similar reductions in VO2 max, maximum oxygen uptake consumption, after bed rest, as well as in patients with long COVID and ME/CFS. However, if we look deeper into the study, into the muscle, they come from different things, essentially. And one of them is the altered capillary supply. Because upon bed rest, we see no reduction in capillary to fiber ratio, but because their muscles become smaller, because of muscle atrophy that is very typical upon bed rest, you see an increase in capillary density. However, if you look at the patient populations, long COVID and ME/CFS, we see, at least in the ME patients, a reduction in capillary to fiber ratio, so capillary refraction. And also the density is not higher as with bed rest, but it's actually lower. So there is something distinct, essentially, that happens with these particular patients that is not explained by deconditioning. And you've seen this slide already by Anouk, because Anouk came to me early or last year, I think. It's like there's something strange with these collagen 4 stainings that we asked the pathology to do for us. And these are the typical examples that you've seen already in her presentation. And we started to quantify this, the basal membrane thickness, as well as the lumen ratio. And I'm super excited, actually, that this is the first time we see a clear cut between all the controls and both long COVID and ME/CFS patients. So we're really hoping that this could also provide maybe a new diagnostic marker. Interestingly, the amount of the capillaries around the fiber times the lumen size really nicely correlated in patients, but not in the controls, also with the power output or the exercise capacity on the bike, so it also has some links with symptomology. We're looking into, with a very specific microscope, electron microscope, into the details about the capillaries. These are very nice capillaries at the bottom with a very thin basal membrane. And we see these very large capillaries and a swollen endothelial cell. That's also on the poster of Anouk, full of vesicles and other structures that we don't really know much about. We see, for instance, structures that are, you see here, like these endothelial cells are full of vesicles. They're excreting things into the circulation, and essentially we don't know what they do there and what their function is, but we try to understand this better. This, I think, is already covered by Anouk in her presentation before the break. But importantly, we're looking for validation cohorts to make sure that the studies that we do are valid across different cohorts from different groups across Europe and the world. So we're really interested for collaborations to see whether we see similar things, and this we can put this into a clinical diagnostic criteria. In terms of time, I really have to be quick, I think. So we also see some mitochondrial abnormalities in our EM images, but I think the next speaker will dive more into this. Lastly, and I think this is the poster that Jelle is presenting, we see lipofuscin accumulation. This is something that our electron microscope technicians highlighted first. They said there's something strange with these accumulation, and essentially this is to do with defective autophagy and lysosomes. And I was just whispered by Jeroen in my ear this morning that there also may be autoantibodies found in patients against autophagy-related proteins. So maybe there is also a link with autophagy and autoimmunity. But we see a clear increase in the long COVID patients in terms of lipofuscin per fiber, and it's even higher in our ME patients. So this is something that we try to follow up on, and Jelle is the person who is presenting this in the poster here. So take-home messages: many patients with long COVID and ME CFS suffer from post-exertional malaise. I really want to highlight that the PEM is not the same as exertional dyspnea or just fatigue. It's really two separate phenotypes and pathophysiologies. Exercise above this PEM threshold is counterproductive. But I think I'm talking to the own church here, because I think it's normal here. People know this, but people outside this field may not. We do know that distinct factors contribute to the reduced exercise capacity and others to PEM, but we don't know the X factor that causes PEM. We also see that skeletal muscle alterations are different from bed rest and post-viral disease, such as ME, and the microvascular adaptations are a possibility and value for diagnostics. And with that, I would like to thank colleagues here, patients, participants, but actually also one thing I really want to highlight here is that we recently got some really good feedback on some of the grants that we submitted, and I'm pretty sure there are some reviewers in the room here, and I'd like to thank you for that, for the nice comments that we received from our work. So thank you very much for your attention.
I think we have time for one question.
Thank you very much for the presentation. So you compared the three groups: normal, long COVID, and ME/CFS patients. So how did you define these groups and differentiate between, in particular, between long COVID and ME/CFS?
That's a very good question. Short answer is the long COVIDs were ill after the pandemic, and the ME/CFS patients were ill before the pandemic started. So they were ill for a longer period of time. We're considering the situation that the long COVIDs are the early phase of MEs. I'm seeing your neighbor nodding. So that we see sort of a continuation of the disease in terms of disease progression.
Okay, but so that means long COVID is also quite similar criteria like the ME?
Yeah, so all the patients had to abide to the CCC criteria and PEM. So all our long COVID and ME/CFS patients were CCC positive and also PEM positive. Physical PEM positive.
Thank you.
Thank you.
Thank you.